Imagine a rugby player goes in for a tackle, grabs the opponent's jersey, and his grip is violently ripped away.
Ouch. Yeah, classic mechanism.
Right. In that split second, the flexor tendon in his ring finger snaps and retracts all the way into his palm, taking its blood supply right with it.
And you're on call and you're expected to fix it.
Exactly. Now, if you are preparing for the FRCS plastic surgery exams, you already know that hand tendon injuries represent, a disproportionate amount of the board's focus.
Oh, absolutely. They love this topic.
So this deep dive is designed strictly for you. We are skipping the pleasantries. We're operating as a rapid-fire, high-yield revision session. Our mission today is absolute anatomical mastery, precise surgical mechanics, and exact rehabilitation protocols.
Yeah, because passing these boards means moving way beyond rote memorization. I mean, you need to understand the biomechanical rationale behind, every incision, every suture gauge, and every single week of physical therapy.
There is zero margin for error in the exams, just like in the operating theater.
Exactly. So we are going straight to the facts, focusing on the underlying why and how of every clinical decision.
So let's jump right into the territory. Before we can even think about repairing that rugby player's finger, we really have to map the anatomy.
Right, the foundation.
Walk me through Verdun's 5 zones of flexor tendon injury. And specifically, I want to unpack why board examiners relentlessly test the complexities of Zone 2.
Sure. So Verdun's zones are your basic anatomical roadmap, right? And we map them starting distally and moving proximally. Zone 1 is entirely distal to the FDS, or flexor digitorum superficialis insertion.
So it only contains the flexor digitorum profundus.
Exactly. Just the FDP. Then we hit the notorious Zone 2, which spans from the proximal flexor sheath all the way down to that FDS insertion.
Which we'll definitely come back to. What about Zone 3?
Zone 3 is your palm area.
Yeah.
So the space between the distal edge of the flexor retinaculum and the start of the proximal flexor sheath. Moving proximal, Zone 4 is located directly underneath the flexor retinaculum.
Effectively the carpal tunnel, right?
Yeah, exactly, the carpal tunnel. And finally, Zone 5 is everything proximal to that flexor retinaculum up into the distal forearm.
And we can't forget the thumb. It has its own, isolated anatomical landscape.
Right. The thumb zones are heavily tested. So Zone T1 is distal to the IPJ, the interphalangeal joint. Zone T2 runs from the A1 pulley to that IPJ.
And T3 is in the palm.
Yeah, T3 is situated right in the thenar eminence. Then zones T4 and T5 simply mirror the finger zones, meaning T4 is under the retinaculum and T5 is proximal to it in the wrist.
Okay, let's circle back to Zone 2. Historically, surgeons called it no man's land. What is the structural reality that makes this specific zone such a nightmare to repair?
Well, it comes down to pure spatial restriction and fluid dynamics. Good. In Zone 2, you are forced to navigate 2 separate tendons, the FDS and the FDP.
Gliding right over each other.
Exactly, gliding over each other within an incredibly tight, totally unyielding fibroosseous sheath. If your surgical repair adds even a fraction of a millimeter of bulk, the tendon catches.
Wow, just a fraction of a millimeter.
Yeah, or if your handling of the tendon ends causes excessive scarring, the tendon will simply lock up. It cannot glide. It is a biomechanical choke point.
So even a technically good suture can yield a functionally useless finger.
100%.
Yeah.
Which perfectly sets up the flexor tendon sheath and the pulley system itself.
Right. Give me a breakdown of how that sheath is constructed, because I know it's not just a passive tube.
Not at all. It's a synovial-lined fibroosseous tunnel running from the metacarpal neck down to the DIPJ. You have to conceptualize it in 2 distinct components.
The synovial and the retinacular, right?
Yes. The synovial portion is the biological engine. It produces fluid for tendon glide and provides vital diffusion nutrition to the, relatively avascular tendon.
And the retinacular portion?
That provides the mechanical efficiency. It acts as a series of straps holding the tendon closely against the bone to prevent bowstringing during active flexion.
And those straps are the annular and cruciform pulleys. If we think of the annular, or A pulleys, as the rigid concrete pillars holding the bridge up, the cruciform, or C pulleys, act more like the expansion joints. Walk us through the sequential order.
From proximal to distal, it goes A1, A2, C1, A3, C2, A4, C3, and finally A5. Their origins dictate their rigidity, actually.
How so?
Well, the odd-numbered annular pulleys A1, A3, and A5, they originate directly from the flexible volar plates of the MCPJ, PIPJ, and DIPJ.
So because they're on the joints, they have some give.
Exactly. But the even-numbered ones, A2 and A4, they are the true rigid pillars. They originate directly from the periosteum of the proximal and middle phalanx bones.
Which explains why those C pulleys need to exist. If the whole tunnel was rigid bone to bone, you literally couldn't bend the finger.
Precisely. The cruciform pulleys are cross-shaped, thin, and highly collapsible. They basically concertina together. This allows the finger to flex fully without the sheath buckling inward.
Makes sense. And how does the thumb pulley system differ?
The thumb only relies on two annular pulleys, the A1 overlying the MCPJ and the A2 overlying the IPJ. But bridging them is a unique structure called the oblique pulley.
Oh, the oblique pulley.
Yeah, it spirals from the ulnar side of the proximal phalanx over to the radial side of the distal phalanx.
Okay, so you're on the table, you're in zone 2, and you need to open the sheath to access a retracted tendon. What is the absolute non-negotiable clinical rule regarding pulley preservation for the boards?
You preserve as much as physically possible, obviously.
Yeah.
But the hard rule for adequate function is the absolute preservation of either the A2 or the A4 pulley.
You have to save at least one of those rigid pillars.
Yes. If you sacrifice both A2 and A4, the tendon pulls completely away from the axis of the joint. You get severe bowstringing.
And a massive loss of mechanical efficiency.
Right, resulting in a patient who cannot make a fist no matter how intact your actual tendon repair is.
Let's shift from anatomy to injury mechanics. Let's go back to our intro hook, the rugby player. A patient presents with a Ruger jersey finger. Mechanically, what just happened?
A Ruger jersey finger is a traumatic avulsion of the flexor digitorum profundus right off its bony insertion on the distal phalanx.
And biomechanically, how does that happen?
It requires a very specific opposing force, a sudden, violent hyperextension load applied to an actively, forcefully flexed DIPJ.
So the muscle is firing at maximum capacity to flex, and an external force violently straightens the joint, snapping the insertion point. But why the ring finger? Is that just a statistical quirk?
No, it's an anatomical vulnerability. When you make a tight power grip, the ring finger's FTP anatomically acts as the longest flexed finger.
Oh, interesting.
Yeah, its tip protrudes just slightly further into the palm than the middle or small fingers during active flexion. Because it sits further out, it absorbs the absolute brunt of that sudden hyperextension force.
So you have the snapped FTP. The boards expect you to immediately apply the Leddy and Packer classification to dictate your surgical urgency. Break down the 3 types for us.
So Leddy and Packer categorizes FTP avulsions based purely on how far the tendon retracts and the resulting status of the vincula.
The vincula being the tiny vascular tethers supplying the tendon.
Exactly. Type I is your absolute emergency. The tendon snaps and retracts all the way down into the palm.
Wow, that far.
Yeah, and because it travels that far, it violently shears and ruptures both the long and short vincula. The tendon is completely devascularized and will necrose quickly. You have to repair it within days.
Okay, what changes in type 2?
In type 2, the tendon only retracts as far as the proximal interphalangeal joint. It stops there because the long vinculum remains intact.
So it still has a blood supply.
Right. Because that vascular tether is unbroken, the tendon retains a lifeline, buying you a little more time for the repair.
And type 3 doesn't retract much at all, but for a completely different mechanical reason, right?
Correct. Type 3 involves a large, bony fragment avulsing off the distal phalanx along with the tendon.
And it gets stuck.
Yeah, that chunk of bone is physically too large to squeeze through the tight, rigid tunnel of the A4 pulley. It acts like a wedge, jamming the tendon at the A4 level.
Let's move into the operating theater. This is where examiners really drill into your surgical decision-making. You need to expose this retracted tendon. What are the preferred, board-approved extensile incisions?
Well, rule number 1, never cross a flexion crease at a right angle.
Because of contractures.
Exactly. You will cause a crippling flexion contracture as the scar heals. The preferred approaches are the Brunner incision, which utilizes broad, zigzag flaps intersecting at the extreme edges of the flexion creases.
Or the midlateral, right?
Right, the midlateral incision, which runs along the neutral axis of the digit. Both allow massive exposure without limiting future extension.
So you expose the sheath in zone 2. It's incredibly tight. We know we have to save A2 or A4. But if you've repaired the tendon and it's catching on the sheath, what's an accepted alternative to venting those pulleys?
Instead of destroying the pulley system to make room, you reduce the tendon volume. An accepted board answer is to excise a single slip of the FDS tendon.
Ah, so you still have FDS function, but less bulk.
Precisely. You've instantly created more space within that fibroosseous tunnel, vastly improving the glide of your repaired FDP.
Let's talk suture mechanics. What are the strict physical rules for the core suture? Because we're balancing strength against bulk, right?
It's a very delicate equilibrium. First, you handle the tendon ends minimally. Only grasp the very tips that will be buried in the repair to prevent creating adhesions.
And what about gauge and strand count?
The repair has to be strong enough to handle early active mobilization. So gauge matters. A 30 suture is definitively stronger than a 40, but it adds bulk. Strand count is critical too.
A 4-strand is better than a 2-strand.
Yes, a 4-strand repair crossing the laceration site is vastly stronger than a 2-strand, and the knot mechanics are vital. You must use locking sutures rather than simple grasping sutures.
Why is locking so much better?
A locking suture throws a loop that cinches down on a bundle of tendon fibers that drastically prevents the suture from simply pulling out under tension.
Examiners love to test on the millimeter tolerances of your repair. What is the actual clinical difference between leaving a 2-millimeter gap versus a 3-millimeter gap?
In hand surgery, a millimeter is a mile. If you leave a 2-millimeter gap at the repair site, you alter the tendon's diameter just enough to significantly increase the gliding resistance within the sheath.
Because the body fills it with scar tissue.
Exactly, promoting adhesions and severe stiffness. If that gap extends to 3 millimeters, the biomechanics fail completely. A 3-millimeter gap creates a bulbous mass of scar that is physically highly unlikely to pass under the rigid A2 pulley.
It'll just catch and rupture.
It'll definitely catch, and the repair will rupture.
You also have to worry about over-tightening. Explain Verdun's quadriga phenomenon. If you debride too much ragged tendon and shorten the FDP, you don't just affect that single finger.
No, you ruin the entire hand's grip. The quadriga phenomenon is a classic board trap. Think of it like a Roman chariot pulled by 4 horses tied to a single set of reins. All the FDP tendons to the 4 fingers share a single common muscle belly up in the forearm. If you shorten one tendon by more than 1 centimeter during your repair, you effectively tether that shared muscle.
Oh, wow.
Yeah, so when the patient tries to make a fist, the shortened tendon reaches maximum tension and bottoms out early. The muscle stops contracting, meaning the other 3 perfectly healthy fingers stop flexing.
So you cause a devastating global decrease in grip strength. That is wild.
Exactly.
So, core suture techniques. We need to know the names and their strand counts for the boards. Give us the rapid breakdown.
For 2-strand options, you have the classic Kessler, which leaves 2 knots on the outside surface of the tendon, and the modified Kessler, which hides a single knot securely within the repair site.
And for 4-strand?
For 4-strand repairs, you utilize the cruciate technique or the Adelaide, which is essentially a modified Savage. If you need a massive 6-strand repair, you use the Savage technique.
Good to know.
And a quick high-yield point. There is no literature evidence proving that using a cutting needle increases your rupture rate compared to a taper needle.
That's a great board tip. And once the core is in, we wrap it with a peripheral suture. That's not just cosmetic, is it?
Far from it. Peripheral sutures perform 3 distinct biomechanical roles. First, you usually run the back wall before placing the cord to perfectly align the tendon ends.
Okay, the second.
Second, they tidy up the bulky epithenon following the core suture to ensure a smooth glide. Third, they contribute a massive amount of additional pull-out strength to the overall repair.
What are the standard tested techniques for that peripheral stitch?
The Strickland Simple Continuous, the Silfer-Skewed Cross Stitch, and the Halstead Continuous Horizontal Mattress.
Before we move on to rehab, what about partial lacerations? The boards will give you a scenario where the tendon is, say, 60% sliced but intact. Do we put a multi-strand core repair in that?
No. Tendons are remarkably resilient. Lacerations up to and often beyond 75% of the cross-sectional area maintain adequate strength for physiological loads.
So you don't need a multi-strand core at all.
Right. You do not need a multi-strand core. However, that loose flap of cut tendon will cause triggering against the pulleys, so you must carefully trim the frayed edges flush.
Should we throw a quick epitendinous suture around it just to smooth it out?
Absolutely not. Never put an epitendinous suture on a partial laceration. It is biologically unnecessary.
And it creates more drag, right?
Exactly. Mathematically, the suture material itself instantly doubles the gliding resistance of that segment. Leave it alone.
Perfect. Let's transition from the OR to hand therapy.
Yeah.
A flawless repair means nothing if the rehab protocol is wrong. I want to contrast early active versus passive mobilization regimes.
This is a huge topic for the boards.
Specifically, let's pit the historical Kleinert regime against the Belfast regime. Why did the consensus shift?
Historically, surgeons casted tendons in total immobilization because they believed adhesions carrying blood vessels were absolutely necessary for the tendon to heal.
But we know that's not true now.
Right. We now know that tendons possess intrinsic healing capabilities via synovial diffusion. Prolonged immobilization just guarantees a stiff finger, so early mobilization is vital.
It stresses the tendon to align the collagen fibers.
Exactly, and prevents those adhesions. In all early regimes, you use a dorsal blocking splint for up to 6 weeks to physically block the patient from overextending, and you avoid heavy load for 12 weeks.
So how does the Kleinert regime approach that early movement?
The Kleinert regime is fundamentally a passive flexion protocol. You attach a rubber band to the patient's fingernail and anchor it to the wrist. The band passively pulls the finger down into flexion.
And then the patient actively extends.
Yeah, the patient actively uses their extensor muscles to straighten the finger against the resistance of the rubber band. When they relax, the band passively snaps the finger back into flexion.
But examiners want you to know the flaws of Kleinert. Why are we moving away from it?
Because keeping a finger in prolonged passive flexion creates massive contractures. It frequently results in a severe PIPJ extension lag. The patient literally cannot straighten their middle joint anymore.
And it doesn't really mobilize the DITJ, does it?
No, passive traction is a very poor mobilizer of the DIPJ. The tendon isn't truly gliding effectively.
Which brings us to the Belfast regime. This is early active mobilization.
Exactly. The Belfast regime recognized that the actual tensile strength of a tendon repair actively increases when it is subjected to early active tension.
When does that start?
Begins strictly at 48 hours post-operation. The protocol is relentless. Every 2 hours, the patient performs 2 passive movements to warm up the glide, immediately followed by 2 controlled active flexions within the confines of the splint.
Wow, every 2 hours.
Yeah, the goal is full passive flexion in week 1, progressively adding active load.
Let's talk about how we measure the success of these protocols. Across the board, there's about a 5% rupture and adhesion rate. But the historical outcome measurement to the ASSH total active motion or TAM system is deeply flawed.
Yes, it is.
Why does it flatter a terrible zone 2 repair?
Because of the math. The ASSH TAM calculates success by summing the active flexion of the MCPJ, PIPJ, and DIPJ, and then subtracting any extension deficit.
And the flaw is the MCPJ.
Exactly. The glaring flaw is the inclusion of the MCPJ at the base of the finger. If you have a zone 2 injury, the MCPJ is anatomically proximal to the trauma. It wasn't injured, so it moves perfectly.
So it artificially inflates the score.
Right. When you add its perfect range of motion into the final equation, it inflates the TAM score, completely masking the fact that the PIPJ and DIPJ might be locked completely stiff.
So what is the superior board-tested alternative?
Strickland's system. It completely eliminates the MCPJ from the equation.
How does the calculation work?
You take the active flexion of just the PIPJ and DIPJ, subtract the extension deficit of those 2 joints, divide by 175 degrees, and multiply by 100.
So it's isolating just the injured joints.
Precisely. By isolating only the interphalangeal joints, Strickland's system gives you a brutal, honest assessment of how well your flexor tendon actually glides through that finger.
All right, we're flipping the hand over. Everything changes on the dorsum. The anatomy and surgical strategy for extensor tendons differ wildly.
Completely different ballgame.
Why can't we just use the heavy 4-strand Kessler core sutures we just mastered on the distal extensor zones?
Because you are dealing with a radical shift in tissue morphology. The extensor system has 8 distinct zones in the fingers and 5 in the thumb.
And they change shape, right?
Yeah, proximally up in the forearm and wrist, extensor tendons are thick, robust cables. They can easily hold a heavy core suture. But as they travel distally across the knuckles and into the fingers, they flatten out completely.
They become like ribbons.
Exactly. Broad, paper-thin ribbons of tissue. If you try to bury a thick Kessler core suture in zone 1, it will act like a wire through cheese and rip right through the tendon.
So how do we adapt zone-specific repairs to handle this paper-thin morphology? Let's start with zone 1.
In zone 1, right over the DIP joint, the tendon is barely a millimeter thick. You can't use a core. You utilize a running suture that often intentionally incorporates the overlying skin into the repair.
Pulling it all together, what is that called?
That technique is known as dermatonodesis. Moving slightly proximal to zone 2, between the PIPJ and DIPJ, you have slightly more tissue.
Do we use a core there?
No, you use a running suture but reinforce it with a silver-scaled cross-stitch to grab more fibers.
So when do we finally get to use a core suture?
Not until zones 3 through 5. Here, the tendon finally gathers enough bulk to support a modified Kessler core suture, which you still reinforce with a silver scaled.
And further up in the wrist.
By the time you reach zones 6 through 8, in the wrist and forearm. The tendon is thick enough that you use a standard core, but you can now place that cross-stitch circumferentially for maximum strength.
Let's lock in the extensor rehab protocols.
It is entirely zone-dependent. Zone 1 and 2 injuries, your classic mallet fingers require a splint, holding the DIP joint in slight hyperextension for a strict 6 to 8 weeks.
Just to allow that thin tissue to scar down, what about zone 3?
Zone 3 injuries, right over the PIP joint, require static PIP immobilization in full extension for 6 weeks.
But crucially, in zone 3, you must leave the DIP joint entirely free to flex, right?
Yes. If you splint the whole finger, the lateral bands will shorten and scar down, leading directly to a permanent boutonniere deformity.
And what about the proximal zones up in the wrist?
For zones 5 through 7, you deploy the Norwich regime. You apply a volar splint holding the wrist in 45 degrees extension.
What about the fingers in the Norwich regime?
The MCP joints are flexed past 50 degrees, and the IP joints are fully extended. Controlled active mobilization starts on day 1.
How does that movement work?
For the first month, the patient performs combined IP and MCP extension, but they also perform MCP extension while actively flexing the IP joints, which is essentially a hook grip.
Right, gliding the tendon safely.
Exactly, without loading the repair site. After 4 weeks, the splint becomes night use only.
We have covered primary repair and primary rehab. Let's move to the endgame salvage and reconstruction. What is the board-approved strategy when everything falls apart?
The dreaded salvage cases.
Yeah, the primary repair ruptured, there was a severe crush injury, or massive infection destroyed the sheath. Under what exact clinical conditions would a surgeon opt for a massive 2-stage tendon graft instead of just trying another primary graft?
Well, first, patient selection dictates everything. 2-stage tendon reconstruction is a monumental undertaking.
The patient really has to be on board.
Exactly. The patient must explicitly agree to rigorous, painful hand therapy and multiple operations and acknowledge the high risk of failure.
And biomechanically, what are the requirements?
The timing has to be perfect. All previous skin scars must be perfectly soft and supple, and the joints must be fully mobile. That means their passive range of motion must far exceed their active range of motion.
Right, because if the joint is stiff, a new tendon won't fix it. Assuming they're the perfect candidate, outline the management hierarchy.
Depending on the severity, you can do nothing. Perform a tenolysis to free up scar tissue, execute a tendon transfer, or attempt a primary tendon graft.
But when is the 2-stage graft strictly indicated?
The hard indication for a 2-stage tendon graft is the presence of heavy, dense scar or granulation tissue obliterating the flexor sheath, or total structural incompetence of the pulley system.
You just can't thread a fresh graft into that mess.
Exactly. You cannot thread a fresh avascular primary graft into a scarred, collapsed sheath. It will instantly adhere and fail.
Explain the exact mechanics of the 2-stage procedure. How do we create a new environment for a tendon?
Stage 1 is preparation. You open the finger, clear out the ruined tendon and scar tissue, and lay in a passive, flexible silicone rod known as a Hunter rod, straight through the flexor pathway.
And you fix the pulleys at this stage too, right?
Yes. During this stage, you also surgically reconstruct any deficient A2 or A4 pulleys over the top of the silicone rod and release any joint contractures. You close the skin and send them to therapy.
And then what happens inside the finger?
Over the next 3 to 6 months, the patient performs passive mobilization. The body reacts to the silicone foreign body by encapsulating it, forming a perfectly smooth, highly vascularized pseudosheath completely around the Hunter rod.
So you've biologically engineered a pristine new tunnel, then comes stage 2.
Exactly. Stage 2 is the actual grafting. You make small incisions, extract the silicone Hunter rod, and immediately slide your autologous tendon graft directly into that pristine, highly vascularized new pseudosheath.
Where do we harvest that autologous graft from?
Usually from the palmaris longus, plantaris, or the long toe extensors.
The boards will ask how you physically secure a graft with no tensioning muscle at the distal end.
The crucial rule is that both ends of the graft must be secured strictly outside the boundaries of the new sheath.
Oh, to prevent adhesions inside the new tunnel.
Right, otherwise the knots will create adhesions inside it. Distally, you secure it to the base of the distal phalanx. If the patient has a tiny, viable FDT stump left, you firmly weave and suture the graft right through it.
And if there is no stump?
If there is no stump, you use a bone anchor like a Mitec, or you pass the sutures directly through the distal phalanx bone and tie them over a button on the nail, or route the graft through a transverse drill hole in the bone itself.
And proximally, how do we attach it to the motor unit in the forearm?
Proximally, the absolute gold standard is the Pulvertaft weave.
Because the diameters are different.
Exactly. Because you are attaching two tendon ends of differing diameters, you don't just butt them together. You weave the graft back and forth through the belly of the motor tendon like a finger trap, using a purpose-made instrument, suturing each pass.
And the tensioning is the hardest part there, isn't it?
The most critical step. You must carefully tension that weave to perfectly recreate the natural resting flexor cascade of the fingers.
Oh, how do you check that on the table?
You confirm this appropriate tension immediately by passively flexing and extending the wrist, basically performing tenodesis, to ensure the finger falls into the correct posture.
Finally, you mentioned pulley reconstruction during stage 1 over the Hunter rod. What specific materials are board approved to build a new A2 or A4 pulley?
You have to restore E2 and A4 to prevent bowstringing, as we discussed. Biological options include utilizing free tendon grafts from the palmaris, harvesting a rigid segment of the wrist extensor retinaculum, using fascia lata, or wrapping a spare slip of the FDS.
How are they physically secured?
You fashion these pulleys by wrapping the biological material around the phalanx in a double loop, weaving it through the tiny remnants of the old pulley, suturing it into bone drill holes, or securing it with bone anchors.
And if you can't reconstruct them,
If you cannot reconstruct the pulleys, the mechanics are doomed. Your only remaining salvage alternatives are joint arthrodesis to permanently fuse the finger, or amputation.
that perfectly brings us to our conclusion. To summarize rapidly, true anatomical mastery of Verdun zones and pulley biomechanics, precise control of your core strand counts and peripheral suture gaps, and exact adherence to early active or passive rehab protocols form the absolute triad required to pass board questions on hand tendon injuries.
There is no shortcut. The margin for error is absolutely zero.
Before you take off your headphones, I want to leave you with a final thought to ponder for your revision. We just talked about harvesting biological tissues to reconstruct pulleys over a silicone rod.
Right.
But with the rapid rise of advanced artificial materials like woven PTFE and Docrin for synthetic pulleys, how close are we to a purely synthetic, one-stage solution that makes the exhausting, 6-month, two-stage Hunter rod procedure completely obsolete? Think on the biomechanical implications of synthetic integration.
It's definitely the future.
Now listen carefully. If you want to dominate the FRCS, press follow on the show right now. If you learned something valuable for your revision today, rate this deep dive. Furthermore, you need to get a premium subscription to listen to the Journal Club and the Clinical Cases deep dives. Finally, go to the show notes and leave a comment or question directly related to your board prep or the specific surgical mechanics we covered today. Keep studying, keep drilling the facts.